What a great turnout. And what's exciting to me is that I don't see a lot of familiar faces. Not that I don't love my own gang, but if I can preach to someone other than the choir, it's always a really good night, because I want to spread the good news of hormones. I'm used to saying the good news of the gospel because I'm a preacher's kid, but the good news of hormones, I'm a little bit excited about that topic because of really just the new information that's come about with this topic. It is a lightning rod conversation. If you ever want to get somebody stirred up, you talk about hormones, breast cancer, heart disease, Alzheimer's. My mom took this and she got that, so I'll never touch it. I mean, it's a hot topic and it's emotionally charged for a reason. And I want you guys to know that this topic, more than probably anything I can think of, needs to occur behind a closed door, mano a mano. It's a personalized discussion. What we're going to be talking about tonight are just some generalities in the field, what's changed, what we've learned over the last 25 years, what we got wrong with the Women's Health Initiative in July of 2001, which we're going to talk off a little bit, and starting off to talk some of the myths that came out of that, the generation of women that were denied hormones because of misinformation from that study. What's emerging now, where we're heading, understanding that we handle this topic with the respect that it deserves and selecting the right patient. Now, for you guys that are here, have faith. We're not just talking about the women, which we love the women in our lives. None of us would be here without them, right? And it's equally important, though, that we talk about you. For so many years, I've been in family practice for 34 years now, and the last 17 has been integrative functional. I've had the honor of teaching with the Institute for Functional Medicine on their teaching faculty nationally for the last 11 years, teaching their advanced practice hormone module. I've had also the honor of teaching at Loma Linda School of Medicine, their Department of Internal Medicine and Cardiology, preventive cardiology for the last 11 years as well. And you might ask, why was a family practitioner turned integrative medicine talking about preventive cardiology and hormones? Those things seem as far apart as the Atlantic and the Pacific Oceans. And it's a long story, but the cut to the chase is they're really all very similar related fields. They kind of hold hands. And as you understand the importance of hormones as we age, especially in females, what happens to you as far as cardiovascular risk changing, you see that there's really a lot of overlap. And so something is true with guys. There's a lot of myths, especially in the literature, about taking testosterone and causing heart attacks, heart disease. Couldn't be more far from the truth. And this comes from 2015 with the FDA changing black labels on all the testosterone products based on 3 studies that all 3 of these had major methodologic flaws, to the point where the all-male trial in one of these studies done by the VA had women in them. I mean, it was unbelievable that these things got published. So the 3 studies that were used in 2010, 2013, and 14 by the VA, the NIH, and by the TOMS Treating Older Male study in 2010 were really terrible. It's so much so that we've now had the American Association of Clinical Endocrinology, the American Heart Association come out and say, you got it wrong. FDA, you didn't base your guidelines on good data. So we have these professional organizations who I don't always follow to the T, but when I do vary, I'd better know what they're saying better than anyone else because of the hotness of this topic. It's very litigious. This is an area where if you don't document well that you've had the conversations both with men and women, you can get yourself into trouble with your license. And so I worked hard for that thing. I don't want to see it go away anytime soon. So let's talk a little bit about hormones. Does everyone know that's why they're here tonight? who hears him talk about cholesterol? We could do that next time. But the hormone topic really is a long story. Back in the 60s and 70s, there were a lot of studies that showed, hey, women seem to have less heart disease who are taking hormones. And when you look at the studies, they just say HRT. And the devil's always in the details. What kind of progesterone did they use? What kind of estrogen did they use? What dose? And what form did it get delivered? Was it a patch? Was it an oral tablet? What have you? And it come to find out, it matters. It makes a huge difference as far as risk. So back then they thought, well, there's all this evidence that there's improved cardiovascular. These were all observational studies. These were epidemiological studies. And so you can't make the assertion that there's any causation. You're just showing associations. And so one of the companies that actually made estrogen and progesterone, Premarin and Provera, said, we're going to prove that we're the bad kid on the block, that we're preventing heart disease. So when they did this study and found out that just the opposite was true, they were as surprised as anybody. And it killed their business model, because 50% of women in the United States, after the Women's Health Initiative trial came out and said there was increased risk of Alzheimer's, breast cancer, heart attacks, stroke, hypertension, clots, 50% of you stopped, which, yeah, any person with a brain would do. So they were as surprised as anyone. Looking back over that study in the last couple of decades, that was July of 2001. Some of you are old enough to remember the front cover of Time magazine, Are Your Hormones Killing You? That was the WHI sensationalistic exposure for the first time to the U.S. population. And 50% of women overnight stopped their hormones. And now we're building Alzheimer care units faster than we can buy land. We'll get to that. Put that in the back of your brain. So fast forward, we went back and looked at the Women's Health Initiative and said, what went wrong? We've got all this data from 20, 30 years earlier saying it was protective. And now we've got this one really large trial, randomized, clinical, placebo-controlled, one of the best trials you can do. Tens of millions of dollars were spent showing it's not only not protecting you from heart disease, it's causing strokes, causing high blood pressure, causing Alzheimer's, causing all these issues. How could we have gotten it so wrong? And it literally took till about 2017 to really get a good feel for what happened. And if you look at the scientists in the breast cancer specialty centers that did the original work, a lot of them were the ones leading the charge, going back and looking at this, re-looking at these studies. And not to belabor it, but what they found, and this has all been published, you guys, you're not going to hear this from your OBGYN unless they're more recently trained and very open-minded and reading their own glossy peer-reviewed journals. You're going to hear the ACOG guidelines, which are recommending 20-year-old information, which is be afraid, be very afraid, don't take them because they will kill you with cancer. So what the actual evidence is showing, 2017, 2020, I've got lots of all of us cited reference. This is not just Dr. Holthouse's in my garage on a Friday night when I was bored coming up with these opinions. This is all peer-reviewed data. Randomized clinical placebo-controlled trials have now shown actually it was the synthetic progesterone in that study which caused everything I just said that was negative. All of it. Even the pregnant mare horse urine, Premarin, conjugated equine estrogen, which OBGYNs are still prescribing, was providing safety, preventing, very small, but preventing breast cancer when you separate it out from the women that were taking this nasty synthetic Provera, which is not progesterone at all. Well, why would they not use progesterone? Why would anyone not use a naturally occurring hormone in a hormone trial? Because you can't patent broccoli. You can't patent naturally occurring things. So what do the drug companies have to do to make their profits up on the research they do, which they've done a lot of great things. It's easy to badmouth them because they make so much money and they're corrupt and all kinds of bad things, but they do some good work. I think about friends of mine who wouldn't be alive without lymphoma medications, CAR T, and some things on the advances with oncology without pharma. So it's like we hate them, but we love them. We need them. Long story short, though, they have to alter what's in nature to be able to patent it to make profit. So they took natural progesterone. We call it micronized progesterone. It's abbreviated P4 or Prometrium. Some of you might be on it. You can get it at Walgreens right across the street or Save-On right here. Bioidentical progesterone. They took that and altered it so that they could patent it and made Provera. And there are many different synthetic progesterones out there. We call them progestins. They're not progesterone. It's a totally different drug. It's been altered. And one is deadly killer and one is a lifesaver. The studies show that if you're using natural micronized progesterone along with naturally occurring 17-beta estradiol, which is the natural physiologic bioidentical hormones ovaries make and areas of the body in guys as well, and testes. Guys make estrogen. By the way, testosterone is not a men's hormone at all. It's the most abundant bioactive hormone in the female body, testo. And estrogen is not a female hormone. Guys don't do well at all without it. We lose our bone if we don't have enough estrogen. We have more heart disease if we don't have enough estrogen. So there's a sweet spot for both of these things. So we want to get over thinking of estrogen as a female thing and testo as a guy's thing. That is just not the right way to think of it. So we look back over this data and we're seeing that not only does natural progesterone and natural estrogen not only cause Alzheimer's, breast cancers, clots, and heart attack, it prevents them. And the most preventive window of time is in the first 10 years after menopause. The big question I get is not so much, is it safe between 50 and 60, and is when do I quit? And when is it too late to start? From my female patients. Hello there, guys, we're coming. The data says that after 60, the benefits to cognition, to cardioprotection, avoiding a heart attack, are maybe not as good as that first 10 years, but there's no harm in continuing. So, mic drop statement, when do you as females stop your bioidentical hormone replacement therapy, assuming that you don't have something come up which is a true contraindication? My answer, when you want to stop avoiding having a heart attack, preventing dementias, preventing bone loss, preventing collagen loss, and developing more fine lines and wrinkles, that's when you quit. So, in other words, when you close the door to the coffin, that's when you quit. And I get that question every day. It's not safe. I'm 65. I've missed my window. You're still going to get benefit. And there's a plethora of studies in that back room. I reviewed them again last night so I didn't lead you astray. And I've given this talk many, many times, but the data is ongoing. And the stuff we're seeing is vindicating what these guys went back and looked at WHI and saw. So the take-home message is the type of hormone matters, age matters, and the patient selection matters. What about patients with breast cancer? People are being treated with breast cancers that are cured, in remission all the time now with estrogen. Rebecca Gleiser, who's a oncologic breast cancer surgeon, is making headlines across the nation right now, treating stage 4 cancer with testosterone pellets in the breast where the cancer is, demonstrating the cancer leaving, dissolving. Even Blooming, an MD oncologist, famous, these are celebrity doctors, is published numerous papers on using Premarin. He's an oral conjugated equine estrogen guy, not even a bioidentical necessarily estrogen guy, the 17-beta estradiol. He's showing that stage 4 breast cancer that becomes unresponsive to tamoxifen, the anti-estrogen drug that we use to treat breast cancer, is curing breast cancers. What did we use before 1970 to treat stage 4 breast cancer? Estrogen in high dose shuts off that whole receptor mechanism. What's happened is we've been duped to thinking because a synthetic pharmaceutically created combination of hormones caused this group of problems 20 years ago, that the very hormones we've been exposed to in utero up until age 50 as females is suddenly turned on us and now a villain that causes all this disease. I don't buy it. And the science is now vindicating that it's not about is hormone dangerous or not. It's, is it bioidentical or is it synthetic? So all birth control pills, synthetic progesterone, synthetic estrogen. Unfortunately, we don't have a bioidentical birth control. So what do functional medicine doctors recommend? Probably IUDs as the best choice for birth control. Copper only versus copper with progesterone kind of depends on the patient. Just knowing that progestin in that IUD or in that oral birth control pill is not a good thing. But doses in birth control pills of estrogen and progesterone are many, many times higher than the hormones that we give postmenopausal females where we're replacing hormones. So just to be clear, there's birth control and suppression of ovulation, and there's postmenopausal hormone replacement therapy, HRT. We like to call it BHRT, bioidentical hormone replacement therapy. So that's a huge, huge thing to understand in this. And this has changed within my career big time. 10 years ago, I would be saying the same thing most OBGYNs and primary care in this valley and in the nation will say, even still, following ACOG guidelines, which are based on the fear of 20-year-old data. That is, only give a woman hormones postmenopausally who's ready to blow their brains out because of hot flashes. Their life isn't worth living anymore. Otherwise, it'll kill them. Why would you do that? It's unbelievable, and it's a nihilistic approach, and it needs to stop. We need to follow the evidence, not media, not what's on the cover of magazines 22 years ago, and follow the evidence. And the evidence now is irrefutable. That being said, if you've got a history of breast cancer, if you've got multiple genetic risks, and we now have ways to assess for those things, not just BRCA1, BRCA2, there's so many other things now that we can look for. We got to talk to you about endometrial cancer risk, all of those things. Do you have a clot? If you have an active clot, I'm not going to put you on bioidentical estrogen. So there's a way to responsibly look at risk versus benefit. In fact, there's online risk calculators for breast cancer that we use, and we document them in the chart, and we have conversations that are very individualized. So hopefully that helps clear up a little bit about the history of where we've been, where we've come, the myth busting, the why, and taking out some of the, at this point, ill-gotten fear. I was raised in the generation of doctors that lived through that. And I feel lucky that I'm getting to practice these last twilight years of my career, knowing there's more light, more truth here now coming to mind. So is it to be respected? Heck yes. Is it to be feared as a killer that we thought, looking at the other drugs, the synthetics? The data doesn't support that. It is estrogen, after all. So if you've got mammography, and that's a whole other topic, we can talk about thermograms and mammograms and ultrasounds and MRI. sometime in the future. But if you've got really, really dense breasts, if you've got problems with bleeding that we don't know why it's happening, vaginal bleeding, all these things have to be dealt with. And you have to look at toxins. You have to look at metabolites. How are you metabolizing the hormones we're giving you, or the ones that you have being made naturally, natively? We have to look at your diet, your gut health. Your gut's, by the way, where you metabolize all of your hormones. So a lot of people come in and have hormone imbalances, and the first thing we talk to them about is their gut health. And they'll kind of sheepishly raise their hand and say, I think you got me mixed up with the last client. I'm here for my hormones, and you're talking about intestinal health. And I said, exactly. We're completely related. You have to deal with one to understand and how to optimize the other. Premenopausal, perimenopausal, postmenopausal, very different discussions. Some of the advantages of HRT, we talked a little bit about in brief being cardioprotective. What does that mean? When women turn 50 or go through the change and lose their protective estrogen, a number of things happen almost instantly. The collagen in their skin and their hair and their nails takes a big hit. So they feel like they're drying up everywhere, including their skin. They get more fine lines and wrinkles. Everyone talks about the breast part of things and the sex drive and the sex performance, all that, which is important. But and now they're going and spending a whole lot of money with things at the med spa and the esthetician's office, when in fact their body is starving in a dry desert for estrogen that they once had. Estrogen receptors line the brain. They're all over the colon, pretty much everywhere in the body that you can imagine. You've got estrogen receptors, and you've got different types, 4 different types, alpha and beta being the most studied, one being pro-growth, one being more anti-growth. So there's a whole discussion around that and how to maximize benefit. So there's this collagen issue. Bone health. Did you know that you lose a third of your bone mineral density the first 5-10 years after going through menopause? And that's because when you lose estrogen, remember, a Pac-Man called an osteoclast kind of goes crazy and starts eating up bone much faster than the osteoblast has time to lay down new bone. And so you get this osteoporosis occurring. So you see women catching up and passing men with heart attack risk. Before age 50, you guys are far lower than us. By 60, you've caught up and a lot of you have passed us. Lack of estrogen. But it's not just that, it's the progesterone as well. Progesterone goes to zero when the ovaries go on permanent strike at age 50 as well. And when you lose your progesterone along with testosterone has as much or more effect at maintaining your bone health, preventing cardiac disease, as does estrogen. A lot of OBGYNs, once you've had a hysterectomy and have no uterus, will just put you on estrogen by itself, claiming there's no uterus to get cancer in, so we can give you unopposed estrogen without need for that. That's ignoring all the data that says that progesterone can help with prevention of Alzheimer's and bone loss and cardiovascular risk. Those are big 3 that my boomers talk about. That's what scares them the most, those 3 topics. So we always give natural progesterone along with estrogen, whether you have a uterus to protect or not. Giving just estrogen by itself with a uterus asks for trouble giving an endometrial cancer where you just build up the lining. The progesterone keeps that in balance so that doesn't happen. It also is amazing when you give natural oral progesterone if you've got issues with sleep. It solves trouble falling to sleep with most women, and they say it's the best sleep they've ever had. So progesterone is amazing, not just for cognition, for heart. It's also breast cancer protective. It downregulates that estrogen alpha receptor that's pro-growth. And so there's this yin and this yang balance that is occurring when the two are there. It was always meant to be made together. That's how we were built. It's arrogance for us to think that, oh, you don't need that other half. Let's just throw estrogen at you, in my mind. So we've talked a little bit about bone, breast health, preventive of breast cancer, cardiovascular disease. Probably the most controversial with bioidentical hormone replacement therapy in women in particular is cognition. The progestin, synthetic progesterone in WHI, said it caused Alzheimer's. The group that didn't use that, which was just the oral Premarin, didn't see that same risk, didn't see the stroke risk, didn't see the hypertension risk that was seen. That progestin was nasty stuff. It caused problems across the board. So when we're talking about cognition, there's plenty of data that shows Cache County in Utah has got some great studies, a series on women using estrogen, how long were they on it, the timing, and did they get dementia or not. Come to find out, just like with cardiac prevention, there's a window of opportunity with estrogen that seems to be the best time to do it. The first 10 years after menopause, you're going to get the biggest bang for the buck preventing dementia, just like with preventing a heart attack. Is it more dangerous to continue it after age 60? The data doesn't say that it's something you need to quit because, you're going to get dementia if you're 65 and you're still on estrogen. These are the big issues, the heart, the breast, and the brain with estrogen and bioidentical hormone replacement therapy. That's where the bulk of the controversy has come. So that's a little bit about HRT, where we've come, busting some of the myths based on old data that's been refuted. What are some of the benefits and why? I approach this with my gals very, very differently than I did even 5-10 years ago, where I say, you've got to be at death's door, no quality of life for me to give this stuff to you, because I'm not afraid of it anymore knowing the new data. In fact, now, as long as you're not in a risk category where you're contraindicated to getting hormones, my 55-year-olds have to convince me why I shouldn't give it to them. Why would you not want all those benefits? Okay, you just got diagnosed with breast cancer. Okay, you had a high-grade, high-stage breast cancer that's not fully in remission. You've got an active clot. You had a heart attack or stroke within the last 6 months. There are guidelines from the Endocrine Society that are hard contraindications that we abide by. But there's a whole lot of folks that we're treating now that we weren't before. And I do this in co-managing with breast oncologists. I'm not out there with a GP degree behind my name, the only guy on the chart. I'm doing this in concert with their specialists. The same thing's true with guys. So, prostate cancer is not caused by testosterone. End of story. For 80 years, a guy named, what was his name? Muggins or something. Yeah. Charles Muggins. He was a urologist. 1940, won the Nobel Prize in Medicine. He shared it with another guy that year. They're saying that testosterone caused prostate cancer based on 3 dogs and 1 guy. For 80 years, we've been telling that story. Well, that's been disproven. That's not refuted anymore. And in fact, the guys that are low on testosterone are the ones that present with the highest grade progressed prostate cancer. If prostate cancer was a disease of high testosterone, it would be a disease of 25 and 30-year-old men, not 70 and 80-year-old men that have no T left. This is common sense, but it's taken us that long to get there. Testosterone is associated with not just improved sex drive, but vigor, body composition. It's an anabolic structural builder, DHEA, testosterone. These are the hormones of growth, leanness. And what's happened, the World Health Organization's at a loss. Over the last 30, 50 years, we've seen sperm counts in guys drop by 49 to 50%, and they have no idea why. We in integrative medicine think it has a lot to do with the chemicals we're exposed to. There are pesticides that are estrogen mimics. There's rivers in California, the Salinas River, where the polywogs are hermaphrodites. They don't know what gender they are or anything anymore. And there's this big thing of shift to female frogs. And the guys are all gone because they're getting feminized, estrogenized with pesticides that look like estrogen to the physiology of these amphibians, which absorb everything through their skin, right? In the water they're soaking in. So this has been demonstrated in other species besides frogs, where this kind of thing, our environment is now messing with our endocrine. The World Health Organization has called this, that I'm not a big WHO fan, but they have acknowledged this as one of the biggest health crises facing us, is the endocrine disruption revolution of all these chemicals were in our food, our air, and our water that are known to mess with our hormones. So not only do we want to talk to you about your gut health, but we're going to look at your urine tox burden, PCBs, phthalates, parabens, organic solvents, plastics, BPA. All of these are known endocrine disruptors, which disrupt testosterone in utero and after birth in young boys. We're seeing it in women and in adolescent boys. Phthalates, these are in the Axe, body wash. A lot of the shampoos, a lot of these things that we put on ourselves, personal care products that we use every day. So read those labels and look for methyl phthalate, anything with phthalate in the end, or parabens. Bad news to hormones. And this has been known for a long time. The WHO is published a list of these things, and a list of endocrine disruptions, PCOS, infertility, undescended testicles in infant boys, cryptorchidism is what that's called, hypospadias, genital urinary cancers, endometriosis. So men and women are equally being affected by toxins to a magnitude that we really don't yet understand with their hormones. And it's causing not only decrease in fertility and sperm counts, but to bring this back home, it's causing an incredible problem with low T. I've been practicing long enough now to see this huge difference in my 30 and 40-year-old guys that used to be 800, 700, 1,000 at that age, coming in with 200 and 300 on their testosterone levels. These are guys that have no zest for life. They're growing breasts. They're soft. They have very little muscle mass. They are infertile. They're impotent. And it's absolutely heartbreaking. These are guys that are in the prime of their life, 25, 30-year-olds, who have no ability to do what they're supposed to be doing here on Earth. On the other side of the equation, we have women with endocrine disruption who are growing mustaches and shaving and having PCOS. They stop ovulating because they have an autoimmune excess insulin resistance driven production of male hormone. So our guys are getting more feminized and the gals are becoming more masculinized. And I won't take that conversation any further than that because I don't want to get myself in trouble. I am in Idaho, and I live in Oregon, so I want to be respectful because this is a very hot topic, and gender identity and dysphoria deserves its own talk because it's a serious conversation. I'm here to suggest that the data is now showing that there is a chemical basis for what we're seeing in our culture. And it's not just about sperm counts and testosterone and infertility. I can say this now because this is actually out there. This has been published. And I love everybody. I'm not a hater on anybody. I want to make that comment. So what about testosterone in women? Let's hit that briefly, and then we're going to spend a little bit of time on the guys because these guys have been really patient waiting on me. Let's face it, the women are Ferraris and we're Chevy Chevelles. We're just easier and less sophisticated on many levels. I admit that fully to my wife and to all of you tonight. And it's never been more true than with hormones. Hormones are much easier to manage in guys. It is. I've been teaching it for 10 years than women. Women are far more interesting, guys. Sorry. because no two of them are alike, but there's some pattern recognition when you do it long enough that you go, oh, okay, I see where you're going. I see what your body's telling me. Let's do this. A big area of controversy is giving women testosterone, especially premenopausal women. We do that here by selecting carefully using different modalities. Some people use creams, some people use pellets. I'm a big pellet fan, and I'll tell you why as we get towards the end. But it's mainly something we'll do with women who come in having no sex drive. They're 35, they've had a couple kids, they're putting on some weight around the middle, they're dragging butt through life, and they're just, help me. We talk to the nutritionist. We have them deal with their high cortisol from their stress here. We look at their gut. We look at their toxin levels. But at the same time, if their testosterone is tanking, which women, even at that young age, can start to lose testosterone, it drops about 10 years sooner in women than estrogen, about 10 years before menopause. So a lot of my 40-year-olds who are going to be without estrogen and progesterone in 10 years at age 50, at 40, at 38, 35, they're already suffering from a lack of T. And there are women that need T. And how do I know that? You give it to them, and all the things that I wasn't able to solve, they come back and they love you. You have to do it well, though, because if you overdose them and make them have excessive aromatization and estrogen, if you give them a mustache or acne on their back and they're 35, and that was, 20 years ago, they're going to hate you. So it's this love-hate thing if you cause their periods to get out of whack. So there's a way to do it correctly, and there's a lot of people doing pellets incorrectly. So it's gotten a bad name. The most controversial area is pelleting women with testosterone before menopause. We never use estrogen in a woman before menopause. It's taboo to estrogenize someone who's ovulating and making their own. Their ovaries are still working. Why would you ever do that? But we do know that testosterone in some women starts to really drop. Not all of them. I've got 90-year-olds in my practice who don't need T. It's still really good. So unlike estrogen and progesterone, where they all kind of go kaboom at 50s, testosterone in some women can persist and they just don't need it. What I don't like to see is practitioners that just say, all women need testosterone, blanket. Whenever you hear things like that, run. That's somebody who's just looking at their bottom line, not they've long since forgot their ethics, in my mind. So there's this group premenopausal that can benefit, that's got to be well selected, but you got to talk to them about their relationship with their husband. If somebody's beating them, they're not going to want to have sex with them. I don't care how much testosterone you put in their water trough. So this is the family practice, functional medicine, holistic root cause part of what we are as a core. You have to treat the person in that environment that they live. And you have to ask the hard questions: sexual abuse, verbal abuse, neglect, abandonment. At any point in their life, women, 1 out of 3 of them go through sexual abuse. 1 out of 5 guys, which is a big surprise to most audiences when they hear that. But 1/3 of women in our culture. So we have to ask these hard questions, and we have to deal with all of that before we start throwing anything at them, hormones or what have you. Postmenopausally, it can be a wonderful add-on to estrogen and progesterone for bone health, for breast cancer prevention, dementia, all the cardiovascular, all the same things. It adds to the protection, by the way, of preventing osteoporosis. It adds to the progesterone and estrogen. It adds mostly to improving that libido. So that 60-year-old whose husband is long since given up, or sometimes I see the opposite. It's so cool to see them get that part of their relationship back. It's actually really cool because they come in, they're smiling, and usually he wants what she's got, and so we get them both on the same page. the rising tide that floats all boats, right? And it's cool. That's my lowest priority, but in some people, that's why they come in. And then we talk about all of these things. Then guys, testosterone, low testosterone is a sign of overall men's health. Guys that have low testosterone often have problems, not just with sexual performance and energy and sleep and vigor and lean muscle mass. They could also have cardiovascular problems. There are a lot of studies now showing guys that have low testosterone often are associated with obesity, metabolic syndrome, type 2 diabetes, and pre-diabetes. Treating guys with low testosterone, 2021, UK study, as Australian study, 2 years, improved pre-diabetes and newly diagnosed diabetics, the ones that were treated versus those that were placebo that didn't receive the testo. What was crazy about that 21 trial, it was independent of their baseline testosterone levels. So in other words, guys that are pre-diabetic or already diabetic, often you can bring them back by optimizing their testosterone. And these are not necessarily guys that have a lab that shows it's less than 300 on 2 separate days, which is the current FDA guideline in order for the insurance to cover your Testogel. Okay? So there's replacement on insurance guidelines based on being in the basement, which is ridiculous because most of my guys that need help are higher than that. So we call this optimizing, testosterone optimization. I can't do that through the insurance because the insurance companies are who practice medicine in the United States of America, not me anymore. Sorry. Truth. So we're out here doing cash so that we can do what we know and we're trained to do as medical professionals without any unseen suit in the room saying, nope, you didn't meet that criteria. Nope. You know, we're not going to let people suffer. We're going to select them correctly. So testosterone is equally important for cognition, sexual performance, structural, muscle, bones in men and women. And it can be incredibly helpful for sexual performance, not just for erections and drive, but quality of orgasm for both men and women, which is not something a lot of people think about. It's like, okay, happened, still happens. Okay, there's happens, and then there's 4th of July. Okay. Hormone optimization can bring back a little bit of that Independence Day. So one of the things that I like to talk about after going through this part of the conversation is how do we give hormones? And that's going to be kind of how we close a little bit. We can give hormones orally in a form of estrogen. We don't tend to give it as orally as testosterone, even though there are FDA-approved new oral testosterone supplements. Why? Because that's associated with more high blood pressure and strokes and things like that. When you give oral testosterone, it has to get passed and metabolized through the liver. And so you have to give really high doses to get blood levels. When you give estrogen and testosterone orally, that's kind of the law of the land. That's why when you take a patch of estrogen or cream, you look at the doses and they're in micrograms, not milligrams. That's because when you put something on the skin, it gets directly absorbed in the bloodstream with very minimal need to be metabolized or changed. When you take it through your mouth and it goes through your GI tract and metabolized in your liver, it gets conjugated and metabolized. So really little of it. In fact, the data says as little as 2 to 10% of oral hormone is bioavailable. 2 to 10%. That's a really small percentage. As opposed to creams, patches, pellets going across the skin or being in you, you're going directly in, and there's lots less metabolism. So less metabolism means I can get away with less doses. The problem with giving things orally like estrogen, like Premarin, going through the liver, is that it's known to raise clotting factors, triglycerides, and inflammation, something called CRP, C-reactive protein. When we give that same bioidentical estrogen as a pellet or a patch, you don't see any of that. Less clotting, you don't see the problems with blood pressure, don't see the inflammation markers go up, and you don't see problems with high triglycerides. All estrogens, when it comes to oral versus patch versus pellet, will build bone, help with preventing heart disease, heart attacks, and help the brain. Not all of them are as safe as the others. So when we look at all the data, the transdermal, the stuff either you're using vaginally for gals or patches or creams or pellets are the safest way to get all of those benefits of estrogen. And I would also say the safest way to get the testosterone in you at lowest doses possible without the risk of clots, liver problems, inflammation, and messing up your lipids. Overall, even oral estrogen will improve HDL and LDL. Overall, even oral estrogen will improve your risks of breast cancer, heart attack, and problems with Alzheimer's, cognition. Transdermally across the skin or implanting with a pellet does all of that without those other added risks. So what we do is we look at, are you a good candidate? Are you somebody that it's safe to give? And here's the ways to do this: cream, patch, pellet. We usually get progesterone, the bioidentical progesterone, micronized I mentioned, always by mouth. It's the one that's safe to go through the liver. In fact, we want it to get metabolized because the active metabolite of natural progesterone, allopregnanolone, stimulates the GABA receptor, which is why it puts you to sleep. Natural sleep, not Ambien or, trazodone sleep, artificial sleep that screws up your sleep architecture. And now all these little smartwatches and wearables tell you when you didn't get good, deep stage 4, stage 3 delta wave sleep or enough REM. So I'm a big pellet guy. Guys, here's the thing. Women don't have a testosterone that's FDA approved in this country, period. You feel left out yet? That's why I have this passion for this, because it doesn't make any sense. Testosterone is either injected, cream, or pellet for women. In guys, it's usually injected, cream, or pellet. The problems with creams are that there are things in the skin that alter it. There's something called 5-alpha reductase that converts the testosterone cream that women and guys are using to dihydrotestosterone, the form of T that causes hair loss and acne. So you'll see more of those kinds of problems and higher levels of something called dihydro-T in men and women who are doing topical, because there's a lot of that enzyme on the skin. Injections, which is something more relevant to men, where they're doing testosterone shots twice a week, we see problems with two things. Because you're getting this big super physiologic spike that comes down, and then again Thursday, so Monday, Thursday usually, you have a bombardment, an overstimulation of the bone marrow. So they get really thick blood, and a lot of them have to go donate blood. Thick blood equals stroke, So I'm not a big injectable fan, because that's the only place I ever see a need really to ever go donate blood. And the Red Cross won't take that blood. You have to go to a hem-onc place to pull it off you. So it's a pain. The other problem with injectable with guys is that it tends to cause a lot of aromatization, meaning you inject it and it hits this big bolus, and the aromatase enzyme converts it to estrogen. So they get really high levels of estrogen, especially if they're dealing with a little bit of belly fat, where you got more aromatase than normal, converting it to something called estrone, which is the type of estrogen that causes breast growth. So guys get man boobs, they get gynecomastia, and they say, oh, I need my aromatase inhibitor, anastrozole. No, what we need to do is get rid of this. We're going to address your insulin resistance, which is driving your aromatase overproduction So that, and you see this, it depends what kind of guy you're giving testosterone, what kind of body we're putting that hormone in as to where it goes. Is it going to go DHT, where they're going to get a big prostate and lose hair? And in gals, it's going to give them a mustache and they're going to get hair thin and they're not going to like you and they're going to think it's just thyroid, which is a whole nother discussion because it talks to each other. So getting too much stimulation can cause too much estrogen. The biggest problem, though, is that excess red cells, the hematocrit goes up. It's the opposite of anemia, and they have to pull your blood. So pellets. I was a pellet basher, Nathan, sorry. Up until probably, I've been pelleting for about 10 years ago. Had some bad experiences with some of the pellet platforms were out there. I didn't have all the education I needed. And the pellets that I was using, even though they were from a compounded, certified, FDA-inspected pharmacy, didn't have some of the things we have now. Nathan's Avexia's platform is the one I'm using, and it's made me a believer again. The problems that they've solved for with pellets were, when you put them in, they can fall out. And I've never had it happen since using his Avexipel. And there's reason for that. The other issues is that when you're putting pellets in every 4 months for women, every 6 months, twice a year for guys, they can be problematic where you get kind of these sporadic absorption rates with some of these other pellet companies. They've solved for that. When we're putting these in, it's a minor procedure. It's not even an incision, it's a puncture. It's right in the top of the glute for the gals and right here in this spot in the hollow on the guys. And there's reasons why we do that. Basically, you slip them in there, up above the muscle and just below the fat layer, and you slide them in there and you put a steri strip on and you say, see you in 6 months. So it's 5-minute procedure for women, 10-minute procedure for guys. Guys get more pellets because they need more T. We pellet with estrogen in women and testosterone if they need it. Always oral progesterone. They make progesterone pellets, but I don't think that it's the best way to go. And Avexipel doesn't make them for that reason. It's my understanding, Nathan. The progesterone in a pellet. Yeah. It's all oral and I think that's the best science. So you might say, well, why would you want to do a pellet? Well, pellets are cool because you don't have those problems with aromatization, too much problem with excessive bone marrow stimulation, having to donate your blood. You don't tend to see the crazy swings with dihydrotestosterone. It just works more physiologic. You put them in there, they dissolve into a matrix, and they just kind of leach out over the months. And the dose is based on your symptoms in your lab tests. That's how we figured out. There's a platform, a dashboard, and I have veto power based on how active you are and things like that, because those things can determine nuances on the dosing. And as we put them in, we're tweaking this dose based on how you respond. A month later, when the patch is peaking at your testosterone or your estrogen levels, we do a complimentary call and we talk to you about how you're feeling. Here's your lab results so that we know whether or not to give you a boost. We do a free booster, and that's one of the things I like about that company. They give you a free boost in a month if you didn't feel any benefit, if it's appropriate. They have packed these things. They're made from yam into a powder, and they pack them into these little pellets. If you've ever played the game Battleship, the guys' pellets look like that. The women's pellets look more like a grain of rice. They're way tinier. And they compress them this way instead of this way. When you do it this way, come to find out, you get hot spots and air pockets. So through the 4-month dosing interval, women especially will come in and say, I feel like it's not working as well. It worked really good that first month. So we've kind of solved for that where they're manufacturing it, packing it this way as opposed to vertically. You avoid that. They put a microdose of steroid, triamcinolone, in there, 0.04 milligrams, so don't worry about any kind of steroid side effects, that inhibits potential scarring and your body's immune system spitting them out. So I don't really like I used to by saying, oh, you can't lift weights or do lunges or anything for, 5 days. The manufacturer still recommends modifying activity, but you're not out of life as long, especially with putting them in the guys here as opposed to in the glute, where there's a whole lot more movement and risk for things getting pushed out. So I don't see the extrusions. I've never had an infection. 34 years doing that. The technique is an atraumatic technique, so you're not cutting. You're waggling, is the term we use, through the fat cells. So instead of breaking them, you're just moving past them and laying them out as you come in a row. And so that's pellets. Pellets are not FDA approved. There is an FDA pellet called Testopel, which we don't recommend because it's associated with bad side effects. It's got a bunch of chemicals in it. And so I don't use those. We use the ones that Avexius and some of these vetted compounding pharmacies are making through sterile process, and they're FDA inspected. So pelleting, it depends on who's doing it, the technique, and what kind of pellet. Not all pellets and not all pelleters are created equal. That's kind of your take-home message. So the photo you guys have with Avexipel is more specific about the pelleting itself. We do injections, we do creams, and we do pelleting. I don't treat anyone with oral estrogen for all the reasons we talked about. So that's kind of something we just don't do. Where are we at with time, guys? 7:15. So I need to wrap up. So one of the things we do here, besides hormone consultations at a really deep dive level, and pelleting being, a big part of that, is anti-aging. Hormone optimization is one piece of a precision age reversal Par 1 course that we offer here. It's a year-long package where we're looking at genetics, we're looking at basically your gut health, your toxic burden, your food allergies, food sensitivities. We're looking at things like estrogen and deep dive metabolites of your hormones using things like the Dutch test. We're looking at gut absorption, inflammation, malabsorption, maldigestion with stool studies. We're looking at vascular age. We're looking at your biologic age. How old is your immune system? All this stuff's measurable now. It's kind of crazy. We're looking at longevity specialty lab panels. We're doing peptides. Some people are benefiting from things and not just talking about Ozempic, benefiting from things that can be helpful for sleep, for hair growth, for dementia, for chronic neurological diseases, orthopedic problems with peptides, along with the nutritionist, a personalized diet plan, health coaching to lower cortisol, which drives a lot of these diseases, and a bunch of visits with me over the year. So we measure things, age, vascular, and other biologic age parameters in labs at the first and at the end of the year, and see if what we did here in the middle moved the needle. So for the first time, we have the technology to actually say, we're going to prove to you that what you paid us to not just have you potentially live longer, but live better, actually is working. Don't just take my word for it. There's the data. So we look at deep dive hormones, deep dive cardiovascular health, lipid panels, advanced cardiovascular profiles in this Par 1 program. Testosterone and hormone is one aspect of it. And I just wanted to make that pitch because that's my other baby. And I love to talk about longevity. Any of you who have listened to Peter Attia, David Sinclair know what I'm talking about. So we've taken their books. I've read all 4 of these longevity authors this last year. We've gone to some practices in Sarasota, shadowed them, and we've taken what we've liked and left behind what we didn't like and added things that were nuanced. And I'm pretty proud of this program. It's very personalized. That's called Par 1.